the orthognathic, we are going to divide this topic into three parts. The first part is obviously the planning and diagnosis and treatment that we are going to do today. The second part we'll see the osteotomies of the mandible, and in the third part we'll see the osteotomies of the maxilla. Now you can imagine how important this current topic is because I am dedicating my full lecture on this. That means that it has some weightage. If you want to work orthognathic surgery on somebody, it never works like a third molar extraction. You cannot have a person come into your office, you give them anesthesia and do the extraction. Orthognathic surgery is much complicated. There's extreme amount of planning that goes into it, and the success of the operation depends on the right diagnosis, right treatment planning, and obviously the execution of the surgery. Anything going wrong, you might botch up the surgery and it might have very severe consequences on your patient. He might sue you, you might lose your practice. The patient might go into depression because you are going to change the face of the patient by this operation. Is that clear?
Yes, sir.
So, as we know, face is the most prominent and expressive part of the human body, right? When your teacher is angry about something in the clinics, you immediately come to know about her anger or his anger by looking at her face, right? You will be able to know that, okay, now this is going to be really tough. She's really mad. But that is just one expression. You can easily come to know if somebody is happy. You can come to know if somebody is sad. It is so expressive because facial expressions, they are so sensitive. And they are so well innervated from the brain that even a slightest change of the emotion can be very easily be expressed on your face. So face is very important and the most prominent expressive human body part. Then there is the concept of beauty, right? It is very subjective concept, but a very important concept. If I tell Atharva tomorrow that can you measure the beauty of roll number 97 in your class, he won't be able to tell me in units. He won't be able to tell me that roll number 97 is 97 millimeters beautiful or 1 kilogram beautiful, something like that, because there is no objective measurement that we have. But what not like it, because he has a different idea of beauty. I have a different idea of beauty. Roll number 97. Does that exist in your class? Roll number 97 is there in your class or no?
No, sir. We are till 95.
Okay, so roll number 95. So let's stop there. Roll number 95 has a different idea of beauty. It depends on the race, age, and sex as well. Because might not be an Asian man would not agree to it. So it depends according to the race. It depends on the age. It depends on your gender. It is very subjective, but it is extremely important, because it depends. Your physical appearance has a significant role in the development of your self-esteem, in the development of interpersonal relationship, and if somebody goes to the corporate branch later on and start working, you'll come to know that even in dentistry for that matter, everywhere, even the employment opportunities and the quality of life depend on your physical appearance. I don't know whether you might have faced it or not. You're too young for that, but once you come out into the real world, you might feel that, or you probably might have heard about it a lot. So it's a very important concept. Now, definition, this is very important from your exam points of view. In practice, nobody really cares about what the definitions are. So, from exam point of view, orthognathic surgery is the procedure by which a dentofacial deformity and malocclusion are corrected with orthodontics combined with surgical modification of the facial morphology and various soft tissue structures. So, what we do is orthognathic surgery is a branch where the patient has some kind of dentofacial deformity. It could be just the teeth, just the alveolus, just one jaw, like just the maxilla, just the mandible, the entire mid face or the entire face. So we can actually correct everything, and as you see, orthodontics is very important part of it because it's an interdisciplinary branch. We usually work with them to adjust our occlusion. And one more thing that you must have noticed from this definition is it's not just an aesthetic procedure. It's not a cosmetic procedure. It also involves malocclusion. So it also has a role in the function of the human body. So it changes your appearance. So it is definitely a cosmetic procedure, but it also is very important to get the normal function, the normal chewing of the patient back. A little history. I don't want to waste my time in this. You will find this in any textbook that you are reading. I would suggest Dr. Malik's book to refer, or you can refer the contemporary oral maxillofacial surgery. Both books are really nice. At your level, Dr. Malik was my teacher for my MDS, so I know that the book is really well, and she's done it very well. So I can definitely endorse that book. Just to recap a little bit about the history, you just see that Simon Hariharan was the first one who actually gave mandibular subapicate osteotomy. Then, as humans, we keep on improvising, we keep on improving. Then, things started getting more severe, more serious. People started doing more and more. They started going from just the teeth till the maxilla, then the base of the skull. And finally, in 1992, Joe McCarthy from New York, he actually gave a procedure where you can actually elongate either the mandible or the maxilla, which used to be done on the limbs. When somebody was very short, they used to do this distraction where you just cut the bone and put a screw and just rotate the screw every day, so the bone actually grows, and along with the formation of new callus. So that we'll actually see in the osteotomy parts when we go there. But right now, history is again, it's not very important, but maybe, sometimes the important dates you need to know. You might be asked an MCQ or a short answer about the history of orthognathic. All right, so far so clear? Anybody has any question? Just in Zoom they have a raise your hand option. I don't know whether in Teams they have it, but we can do it later at the end of the chapter. All right. So moving on. As I said, orthognathic surgery is not like you can just get the patient in your office, give the patient some anesthesia and operate. There is a very set of things that you have to follow. There is a patient selection, first of all, that you have to make sure that whatever surgery you are going to do, is that going to be the correct surgery for this particular patient. That is very important to know, because if you do something wrong, if you are not able to make the right choice, then, as I said, it has really, really detrimental effects on the patient's psychology and also the appearance. So how do you select a patient for orthognathic surgery? Well, when the patient has malocclusion, but there is a good skeletal jaw relationship, orthodontic tooth movement alone is usually sufficient to correct the crowded and irregular dentition. What does that mean is that the jaws, they look nice, they are properly placed as with respect to each other and with respect to the base of the skull. Only the teeth are a little crooked, right? In that sense, you can just refer the patient to an orthodontist who would just start a fixed orthodontic appliance or whatever works best for that particular patient according to their analysis, and they can just bring the teeth in the normal relation, and the patient will be happy. But in case of severe malocclusion, a jaw discrepancy will also often exist, meaning that the mandible or the maxilla, they are too forward placed or too backward placed with each other, and that can be a possibility. So if that is the case, there are three different methods that you can treat the patient with. First is growth modification. Now, what is the most important thing for growth modification to happen is that the patient should have growth left in him, right? We all know that growth stops after some time. And the patient, especially in the girls at around 16 and boys at around 18, after that there is hardly any growth possible. So, growth modification usually happens in a mixed dentition age, and there is a lot of growth possibility still left in the patient. At that point of time, they give certain appliances, face mask. You probably must have heard this term in orthodontics. I'm not sure whether you have, but if you haven't, you will definitely hear this term very soon in orthodontics and pediatric dentistry. growth modification is a very important part where they actually induce growth, the right growth in the mandible or the maxilla by various appliances. Second is, if the discrepancy is very small, then you can just camouflage. Camouflage is basically, I don't know what you know about this term, but the military people, they use this quite a bit. They have this typical green dress because of a reason. They want to camouflage themselves in the desert or in the rocks. That's why they have that particular thing. Similarly, in orthodontics and orthognathic surgery, we can use camouflage by giving the teeth, just the teeth, not changing anything about the jaw, just the teeth, the right amount of position, so that you can camouflage the discrepancy of the jaws. But mind you, this happens only when the discrepancy between the jaws is very, very minimal. You cannot, you have a 10 millimeter deficiency, you cannot treat it with just camouflage, because the teeth are just going to fall out of the jaws if you try to move them forward quite a bit. And the last part is the orthognathic surgery, which is what we are going to learn in this, and we have to definitely do this in conjunction with the orthodontist. Alright. Growth modification, as I said, is desirable approach to skeletal problems, obviously because it is the least amount of invasive. There is just an appliance that is given to the patient, and you try to get the growth back so that you don't have to do any operation. Now, the most important and the most severe is obviously in orthodontic surgery, because you're actually opening the jaws, they're cutting the jaws and bringing them forward or back. So it's basically a little more difficult operation and more demanding operation. So growth modification, if not, then try to do camouflage, and if at all both of them fail, then the last option, the last resort is the orthognathic surgery. Now, I don't know whether you have seen this or you know this concept. If you read the orthodontics from angle, then you'll be able to know about it. Have you heard about this concept, people? Envelope of discrepancy, yes or no, Sutri?
No, sir. No, sir.
Let me spend a little bit of time. It was introduced by Prophet and Ackerman. Do you know there is a textbook by Prophet? Yeah. So in that you can see this particular diagram. Now, what basically, it is a very simple diagram. There are different positions of the teeth. So this particular thing is the upper jaw. This is the lower jaw. This is the mandible. The upper one is the maxilla. Okay. Now this is the position initially where the patient is. Now this diagram shows us how much amount of movement, either up or down or back or front of the teeth, we can do in an adult with just an orthodontic treatment. Okay, so this is a limit. There is a limit of how much we can move the teeth ahead. Now in maxilla, the incisors can be moved a maximum of 7 millimeters by just the tooth movement. The middle tooth, the middle segment, the 12 millimeter, is represented by both the tooth movement and growth modification. So we can do this in kids who has some amount of growth left. And the outer circle, the 15 millimeter anterior, signifies that this is the amount of correction that we can get when we do an orthognathic surgery on the patient, right? Just by tooth movement, we can intrude or extrude rather by 2 millimeter only by orthodontics, by 5 millimeters if we use growth modification and orthodontics, and 15 millimeter extrusion with an orthognathic surgery. Similarly, this and this axis, if you want to move the tooth back, these are the three circles and the amount of movement that can be done by each procedure. Similarly, for mandible, you can see we can do a 25 millimeter anterior advancement of the mandible using orthognathic, and just around 2 and 5 millimeters by using orthodontics and growth modification. So you can imagine the amount of power, the amount of difference that an orthognathic surgery can bring about. 25 millimeters forward movement of the jaw, of the tooth. Now, as we know, we have to have certain indications of orthognathic surgery. We cannot operate on any cases. There are very, very selected problems that we need to find out. The first is when the patient has severe class 2 or class 3 skeletal discrepancy. Now, I expect that you know what a class 2 and class 3 occlusion, malocclusion is. Yeah? Okay. So, I'm not going to teach you because that is totally out of my purview. Uh, uh, that is one of the major indications when the patient has severe class 2 and class 3 skeletal discrepancy. The patient might have a deep overbite. The patient might have a severe anterior open bite or extreme vertical excess or deficiency in the mandible or maxilla. There can be severe dentoalveolar problem. The patient can be severely having a periodontal situation which is compromised. So, when you try doing orthodontics, the teeth are basically going to fall off the jaws. So, we cannot do orthodontics in those. And where there is a severe amount of skeletal asymmetry. So, these are the indications of orthognathic surgery. This might be asked to you as a short answer if that is still a trend. This is a very important point that you need to know why and when you should do orthognathic surgery. Now we have to evaluate the patient in 4 areas. The first is we have to talk to the patient. Okay, you cannot, I cannot overemphasize the importance of good consultation with the patient. You need to see what the patient wants. You have to see what kind of awareness the patient has, what kind of problem he has, and the most important thing is we need to know if the patient is having realistic expectation from the operation. If the patient comes to you and he looks like who is that WWF wrestler, big guy, 7 feet or I don't know 8 feet from India, Khali, I think Khali. If he looks like Khali and he wants to become Shah Rukh Khan by an orthognathic surgery, it's not going to happen. So we need to find out whether the patient has realistic expectations or not. If find that the patient may not have realistic expectation from the operation, it's best that you tell the patient to avoid the operation, because what is going to happen is you are going to, as a surgeon, are going to be in big trouble. The next thing you need to do, and the very important thing that we are going to cover today probably, is the clinical examination. You are a physician, you all are physicians, clinicians. You have to know that the most important thing that you do in a clinic is you have to do the examination of the patient. Even if the patient says that I have a grade 3 mobile tooth and I need an extraction, many times people miss a thorough examination of the patient and they land up in trouble. They miss a hyperthyroid, a thyroid swelling sometimes, and they just inject the patient with LA, with adrenaline. Patient might go into thyroid storm and you might land in big trouble. So clinical examination, a thorough clinical examination is very important. It should not be just focused to the area of problem. That's why we have a very, very big sheet, and sometimes you might wonder why we are wasting so much time. I can see the tooth, it's mobile. Even if the patient sneezes, it's going to be out. I just want to take my forceps and remove it. But there is a very important result that is designed for. Okay. But the next is radiographic and imaging analysis. Many times, many surgeons, many clinicians, especially young doctors, young surgeons, they make this mistake of giving more importance to radiographic and imaging analysis to clinical examination, and they end up into trouble. Radiographic analysis and imaging analysis are adjunct to clinical examination. They are they put done ex IDs. The protagonist is the clinical examination. So the hero is the examination, and his sidekicks, they are the right radiographic examination and other things, that imaging that you need. Always. I think this would be helpful for you to remember for the entire life now. Examination is more important. Lastly, we need to see the dental and model analysis. We'll come to that, what it is exactly. It is very important also. So all the 4 things are important. As we say, the first thing what comes into the case history is the chief complaint. And how should be the chief complaint be recorded? Roll number 25 is there. Roll number 25. Roll number 27. Roll number 22. 22 is there for sure.
Yes.
Can you tell me how the chief complaint should be recorded?
The chief complaint is recorded in the patient's own words.
Yeah, that's how it is recorded. I might cold call you. okay suddenly. So that helps me to know that you are not sleeping. And if you don't answer, it's fine. If you answer, it's fine again. So don't worry, don't get scared if you get cold called. Right, patient's chief complaint is recorded in patient's own word. That is very important. So we come to know the real problem that the patient has. And in this case, if you see, they generally have a concern or problem with their function and appearance. They will say, I don't look good. I'm not happy with this mandible protruding outside, or they will say, I'm not able to chew properly and have a lot of issues because of that. They usually want treatment to overcome a feeling of inferiority or insecurity that is related to the dental and facial appearance. These people who don't appear normal, they or who have facial differences, they seem very timid. Their self confidence is extremely low. So it is very important, and everybody deserves to have, everybody deserves to be equal in the society. There is right of equality to everybody, and you as a surgeon, as a physician, has this responsibility to give that equality back to this patient. So by operating on them, we'll be able to give them that security and that feeling that they belong to the same society as we all live in. So it's very important that we do that. They also want to improve their oral functionality. As we said, they probably, if the mandible is too protruding or the maxilla is too small or too protruding, the teeth, they don't sit on each other. So when they chew, they're either in or out, and, the function is not as good as it should be. So, they suffer from a lot of digestive problems. Chief complaint gives considerable insight into what is more important for us to do, and that information is vital for the rest of the diagnostic and treatment process. So never ever miss a chief complaint, not for orthognathic, not for cleft surgery. Anything that you do in dentistry or surgery, chief complaint is very important. I don't know how many people have heard about golden ratio. I'm not going to cold call anybody for that. It is a very important concept for beauty. It is, in simple terms. Now you can Google it later on, but in very simple terms, in any given situation. Now suppose this is a rectangle, A plus B, that is the width of this rectangle to the height of the rectangle, is that ratio. If you find out, it is supposed to be 1.618. Okay, this is the golden ratio. It is followed by everything that you feel is beautiful, right from the face of Madhuri Dixit. If you measure the face of my Madhuri Dixit or Aishwarya Rai, the ratio would be 1 point or very close to 1.618. Taj Mahal, credit cards, Mona Lisa, anything that you feel is beautiful, they usually follow this golden ratio. If you see your teeth, the teeth, the central incisor, lateral incisor, the canine, the amount of show that each one has to have, again, it follows the golden ratio. So, and the golden ratio is followed. Like if somebody has a smaller central incisor and a more bigger lateral incisor, the smile is not good. It's just not good. So the aesthetic dentist, they have this formula handy when they're designing your smile. Leonardo da Vinci, he knew about this formula way long back when he designed or when he painted Mona Lisa, and it actually has the golden ratio incorporated into it. So we have to find that. That's just a concept, but there is very, very objective way that you can actually see whether the patient has symmetrical face or not. Now let's see how we can do that. First of all, we have to make the patient sit upright in a straight back chair, directly opposite at the eye level. I'm sure you must be knowing what the Frankfurt's horizontal plane is. It has to be parallel to the floor. Once the head is oriented properly, the mandibular condyles should be seated in the glenoid fossa. Many times the patient has this habit of moving the mandible forward and trying to get that. They are very conscious about their appearance, and they keep doing that to negate the kind of jaw deformity that they have. Then we evaluate the centric occlusion and the centric relation. Again, something which I'm not going to do. we have to see that the patient is relaxed. We have to know how much is the discrepancy. Many times, the patient who have teeth, treating teeth, they have this habit of doing this to their lips. They're trying to keep, closing the lips on purpose. I don't know whether you have seen that, but this is a very common habit that they have, and they have developed over the period just to hide the kind of discrepancy that they have. But we have to make sure that they don't have to care about it. They have to be relaxed. We need to evaluate the patient properly, and it is very important that they are relaxed for that. Now, what we do is we see the frontal analysis of the patient. What does frontal analysis means is that you're basically looking at the face from the front. The patient is sitting in front of you. You're in front of the patient, and you just see how the face looks. Now, there are 5 different types of analysis in this. First is the facial form. Second is the transverse dimension. Third is the symmetry. Fourth is the vertical relation. And lastly, it is the lips. Okay. Now, what do you mean by transverse facial proportions? Basically, when you divide the face into 5 parts, 1, 2, 3, 4, and 5, by imaginary lines. Okay, you don't have to take a scale and a pen and actually start drawing lines on the patient's face. That won't go very well with the patient. So just try to imagine the lines. The face is divided. It should be divided into 5 equal parts. The outer fifth is measured from the center of the helix of the ear to the outer canthus of the eye. So this is the first half on both sides. Helix to the outer canthus. The medial 2/5 are measured from the outer to inner canthus. So this is the second line that you imagine. And the third obviously is between the 2 inner canthi. So we have 1, 2, 3, 4, and 5 parts of the face. All the 5 should be equal, symmetrical. If they have it, then they basically probably don't need an orthognathic surgery because they have a good looking face. The second thing you look for is where the lips and where the ala, the outer margin of the ala should be. The outer margin of the mouth should be approximately between the inner margin of the iris. This is the iris. The inner margin, you draw a straight line down from both sides, and that is where your commissures should end. But the lateral part of the ala, they usually coincide with the inner canthus of the eye. Facial symmetry, again, is very easy. You just have to, don't have to draw any lines on the patient's face. You just see, and if there is a gross swelling or gross asymmetry or something which is not showing on the other side, you may immediately be able to know that the patient has facial asymmetry. Now, my question to roll number 22. Roll number 22 is present? Bhageshri, no, you already got a chance. Roll number 84 is there? Roll number 84, Muskan?
Yes, sir.
Can you tell me whether the face in normal patients is exactly symmetrical or there is a mild difference?
No, sir, there is a mild difference.
Yes, very good. So there is a definite asymmetry. There is a mild asymmetry that never the patient has exactly symmetrical face, and that's what you're supposed to know. Otherwise, you'll probably start operating on every patient on the planet, which is not good. So we need to know that there is a mild asymmetry which actually makes a patient good, and we need to respect that. Alright? Then we go to the vertical relationship. What we do is we divide the face into 3 equal parts. The first line is at the hairline or the trichion. From there to the glabella, that's the first line, the first half of the face. The middle half of the face is from the glabella to the subnasale, which is right there. And the third half is from subnasale to the menton or the chin. So 1, 2, and 3. All the 3 parts should be equal. Now, if suppose the first part is bigger, if the first part, the upper part or the upper third is bigger, what does that tell us? What does that tell us? Roll number 17. 17 is there? No. Roll number, who's present? Roll number 21. I'm going to remember these numbers, okay, during the attendance. So I know who is present. Roll number 20.
So I'm 17. I couldn't hear.
Right? So what was I asking? I was asking roll number. What is your name? Roll number 70.
Asmi.
Okay. So you have to tell me what will you know if the upper half of the face is bigger than the middle and the lower. What can it tell us?
So can you repeat the question?
I'm asking. We have divided the face into three halves. If the first half, the upper half, bigger than and they should be equal in an ideal world. But if the upper half is bigger, then what do we know about what can we know about the problem that the patient might have? Or in short, which conditions will have a bigger
Sir, I don't know.
Okay, anybody else that knows? Not able to hear. Somebody speaking something, but not able to hear. Atharva, are you speaking something?
So the patient might be suffering from hair loss.
Yeah, right, correct. That is.
So it could be Down syndrome.
Yeah, so we are more concerned with the shape of the skull. Okay, there are different conditions, craniofacial conditions like trigonocephaly. I just want to give an example. Don't take me very seriously on the terms. Trigonocephaly is when the patient has a skull in the shape of triangle, or a scapocephaly when it looks like a boat. So basically, the skull is bigger or smaller. Microcephaly. So in that case, this part is going to be shorter. All right. So that is something which we come to know, the skull shape and size. Now the next question is, if the middle third is discrepant, what will we know? No idea? If the middle third is smaller, then we know that there is a deficiency of the middle third of the face, right? Patient might have Cruzon syndrome or Apert syndrome. I don't know whether you've heard about these terms, but there is severe detrusion of the maxilla, right? So that is something which we'll be able to know by this analysis. And last but not the least, the lower third. If the lower third is discrepant, if the lower third is smaller, then the patient might have a retrognathia. The lower third is bigger, the patient will have a protruding jaw like a class 3 malocclusion. Okay, so that's the three things that we come to know by this analysis. Right, that's what I told you. Then you can also see the cheek lines. Again, if they don't follow the nice curvature, you might know that the patient might have a middle face deficiency. Alright, so the lower third of the face, there are two things that we need to know. The upper lip length and the lower lip length. The upper lip length, it starts from we know that the subnasale to the tip of the upper lip, and the lower lip starts from the lip to the menton. Now, the normal length of the upper lip should be, in females, it's around 20 millimeters plus or minus 2 millimeters, and in males, it's around 22 plus or minus 2. The lower lip is around 40 plus or minus 2 in females and 44 plus or minus 2 in males. And we also need to check the relationship of the dental midline to the facial midline, which is very important. Then when you're checking the lips, we have to see whether they are symmetrical. They might be asymmetrical in cases of clefts, facial nerve dysfunction if the patient has some trauma and have a scarred lip. And in a normal patient, if you see, the lower lip generally exhibits 25% more vermilion than the upper lip. Okay, that's very important. If the lower lip is exhibiting more vermilion, that means that the patient has a forward jaw or a prognathic jaw. If the vermilion is less, then you might think that the patient has a retrognathic jaw or the jaw is behind. And at rest position, the lips should be around 0 to 3 millimeter apart. If they are always closed, there is some problem with the jaw discrepancy. There is some jaw discrepancy present. Or if they are open, there again is some kind of jaw discrepancy like an open bite. Again, we have to check whether whether the gums are seen. We ask the patient to smile and see. Usually the gums are not seen. If the gums are seen like this, that shows us that it is a case of vertical maxillary excess. The maxilla is too big, so when the patient is smiling, you can see the teeth and the gums, which is not very normal. So we discussed about this when the patient has frontal brushing or supraorbital hypoplasia, exophthalmos, endophthalmos. We have to distinguish that when we see the upper third of the face. Then we come to the nose, which is the most critiqued part of the face. I think if somebody has a bad nose, people keep telling him that we have a really bad nose. It's very, very easily critiqued by people. So you have to see how the nose is placed on the face. The projection of the nasal bridge should be anterior to the globe of the eye by around 5 to 8 millimeters. And then we have to also see vertical ala columella relationship. This is the columella, this is the part which is called columella, and the ala is this. If you see the worm's eye view, then you generally have a pyramidal or a triangular shaped nose. Sometimes this shape is not there correctly, then the patient might need what is called a rhinoplasty operation. You also see the cheeks. You can see the globes are projecting around 2 millimeters more or ahead of the intraorbital rims. If it is not, then you can have either the maxillary hypoplastic or hypoplastic. You can come to know with that. The cheekbone, the nasal tip curve, and the contour should also be examined. The paranasal area should be examined also. So we are basically examining the entire face. When you see the lower third of the face, you need to see the lips where the subnasal hypogonium line, which basically is this line, also called the lower facial plane. It's a very important plane, and the upper lip should be around 3 plus or minus 1 millimeter ahead of this line. The lower lip should be 2 millimeter ahead of this line. Alright, so if you can see, the upper lip is ahead by around 4 millimeters, and the lower lip is ahead by around 2 millimeters. Now, what is going to happen if the patient has orthognathic or a forwardly placed mandible? Obviously this lower lip will be behind the line, and also the upper lip might not have around a 4 millimeter projection. Like in this case, the patient has forward jaw, so you can see this line is pretty straight, and the distance between the lower lip is behind the line, the upper lip is barely behind the line. And if the patient has a retrognathic mandible, then obviously this is going to be more. Then what we need to see is the labiomental fold. This is the fold here. It usually is 130 degrees in dimension. If it is more or less, again you'll be able to know if the mandible and the maxilla are not in the right place. If it is more, the angle is going to get reduced. If the angle is reduced, the mandible is forwardly placed. If the mandible is placed behind, it is the angle is going to go higher. Then the nasolabial angle, it is the measure between the inclination of the columella to the upper lip, and it's usually around 85 to 105 degrees. Again, if the maxilla is ahead, you are going to get a shorter angle here. If the maxilla is behind, you're going to get a larger angle. So, just looking at the patient's face, you'll be able to, you don't even need an X-ray or a CT scan or, any fancy stuff. Just looking at the patient, you'll be able to tell whether the patient has what problem and he needs what surgery. We also examine the chin throat area for the presence of double chin, and adipose tissue should be noted. We need to note this because when you want to move the mandible forward or back, this is the area which might be an interference, and we need to check that out as well. The chin throat angle, which is around 110 degrees, gives a definition to the chin. Again, if your chin is back, the angle is going to change. If the chin is ahead, the angle is going to be lesser. So this again tells you if the chin needs an operation, which is called genioplasty. Then we go on to the oral examination. Everybody there with me, or you need to stop? Is everybody listening? Still awake? Alive? Should we continue for another 10 minutes, 5 minutes, or stop? You can speak a little loudly so that I can hear you
Sir,
clearly.
we have a lecture, sir.
Alright, so we'll stop and we'll do the oral examination on Monday at 9 o'clock. Is that correct?
Yes.
Atharva, I need you to take the screenshot and send it to me.
Sir, I've taken the attendance on Google Form, sir. I'll send it to you.
Alright. Okay. How would you send it to me on WhatsApp or email so that I can
Right.
respond?
I'll mail it to you, sir.
Okay, perfect. Even WhatsApp is fine if that is more convenient to you.
Okay, sir.
Alright, so again, as I said, it's a very important topic. So try to read it today. There are hundreds of videos on YouTube. Now, you guys live in a very different era. In our time there was no YouTube, so it was very difficult to imagine. Orthognathic surgery is something that cannot be taught like this. To be honest, it has to have either a skull or a mandible in my hand at least when we start doing the operations. But what will help is, which is not possible if I get a skull and mandible in my building, I might be banned forever, so I cannot take that chance. What I can suggest rather is you can go on YouTube and check out the videos for sagittal split or maxillary layout one. It's going to be fun. I mean, it's amazing operation. I just love this operation because the patient goes in as a different person and comes out of the operating room as a different person. So I think you'll enjoy it whenever you get time. I know nobody's sleeping before 1 a.m. these days, so 12:30 to 1 a.m. can be the time when you can watch out the videos. So next time we'll look into it in more detail. Okay. If you guys have any questions, we can solve them either next time or the last lecture. Alright, so I'm going to take your leave. Thank you so much for your kind attention, and I'll see you guys on Monday at 9 a.m. sharp. People who are late, they can keep joining. I don't care. You are not kids, just to be spoon fed now. That's all. Alright, enjoy your day and your weekend. Bye.
Thank you, sir. Thank you, sir. Thank you.
Sir गए